Hey everyone, welcome to our NCLEX RN review session on the pediatric brain tumor unfolding case study. And in the session, we'll get into practice tests designed to sharpen your clinical judgment skills and prepare you for NCLEX success. Today, I want to challenge you by following the full case study and dropping your score in the comments below. So let's get started. And here's the case. A 3-year-old male arrives at the emergency department via emergency medical services after a 3-minute generalized tonic-clonic seizure. His parents report irritability, poor appetite, and clumsiness for 2 to 3 weeks with no prior medical or seizure history. And your task is to highlight the findings in the history and physical diagnostics and laboratory results tables that require immediate nurse follow-up. And here are the tables. Now let's go through each of these, and starting with the physical exam details. Patient is lethargic, irritable, responds slowly to verbal stimuli, post-ictal, no focal deficits, Glasgow Coma Scale 14, regular rhythm, no murmurs, respiratory, lungs are clear bilaterally with mild tachypnea, skin is warm and dry, and it says here parents report increased falls and not acting himself. And for the diagnostic tests, it says here for the CAT scan of the brain result, it showed 1 centimeter mass in posterior fossa, no midline shift, mild hydrocephalus, and in EEG, it says focal epileptiform activity in occipital region, and the chest x-ray showed normal lung fields, no masses. And here are some results for the laboratory. Hemoglobin of 12, sodium 135, potassium 4.0, glucose 130 milligrams per deciliter, and calcium of 8.8 milligrams per deciliter. Now you can pause here and scan first, review the data, make sure that you're not skipping any of those very important cues. Now, when you're ready, let's get started answering and highlighting these tables. Now, one of those correct answers is this: lethargic. When you see this patient with lethargy, especially after a seizure, then that is a very serious neurological warning sign. It could mean the brain is under pressure, possibly from swelling or a tumor in the posterior fossa, which is the lower back of the skull. Now, in children, the brain has limited space to expand, so any swelling can quickly cause further damage or herniation in their brain. And you, being the nurse here, should closely monitor this patient, make sure that you follow with the neurological status, especially doing that Glasgow Coma Scale, and make sure that the environment is safe, and immediately notify the healthcare provider for any changes. Now, another manifestation is irritable, or let's say irritability, especially in this patient who cannot explain the symptoms, may reflect brain irritation from a tumor. Could be seizure activity or the early stages of increased intracranial pressure. And when there is persistent or worsening irritability, such as inconsolable crying, which requires urgent nursing attention. And in this case, you as a nurse should administer those medications that may decrease the brain swelling as prescribed, and also to report any behavioral changes to the medical team. Next, we have responds slowly to verbal stimuli. Whenever there is delayed response to verbal cues, that is another sign that the brain may be under stress, and this can result from the recent seizure, could be tumor pressure or buildup of fluid in the brain. We call that as hydrocephalus. And this also overlaps with the lethargy and also adds evidence of declining neurofunction. Now, you as a nurse here should perform frequent neurological checks, keep the environment safe, and escalate any further delay in the responsiveness to the healthcare provider, because this signal worsening pressure or continued seizure activity. Next, we have post-ictal. After a seizure, children will enter into a post-ictal state where they may be groggy, they're confused, sleepy. Even though this is expected, this phase still presents risk. So being the nurse here, you have to ensure seizure precautions are in place, such as padding the side rails or the bed rails, and you have to monitor for their return to their baseline functions. And you need to expect or anticipate administering those anticonvulsant medication as ordered to prevent further seizures, which could elevate their risk for intracranial pressure increase and will also cause more injury. Next, we have Glasgow Coma Scale of 14. 14 out of 15 is not that bad. This shows a mild impairment in the brain function, but even in a single point drop, especially in this patient after a seizure, this is still significant. You need to do frequent reassessment because any further decline could indicate there is an elevation in the intracranial pressure, or it might now involve the brainstem. So your role here should be to do careful monitoring and make sure you promptly communicate any change or deterioration to the healthcare provider. Next, we have increased falls. This is the verbal report by the parent. They said that the patient had frequent falls over recent weeks. And so this one suggests that the tumor is affecting the cerebellum, which controls the balance and coordination. And this symptom also confirms that the tumor is impacting brain function. So being the nurse here, you should immediately implement fall precautions. Make sure that the bed alarm is set and make sure that the patient is not left alone without supervision, and make sure that once it's prescribed, you notify neurosurgery, since these signs reflect disease progression and possible worsening of increased intracranial pressure. Another is not acting himself. Now, when the parents report that their child is not acting like himself, this reflects subtle but very important neurological change. That could mean that the patient has reduced playfulness, could be altered mood, even lack of interest in usual activities. And these changes reflect that there is early brain swelling or it could be damage going on. So when you are interviewing the parents, you make sure that you ask for more detail, monitor for worsening of the symptoms, and ensure prompt evaluation by neurosurgery. And this cue is also critical because small behavioral shifts may be the only sign of serious brain issues in this pediatric patient. Now let's jump into the diagnostic test. And one of those is this one. For the CAT scan of the brain, 1 centimeter mass in posterior fossa, no midline shift, mild hydrocephalus. I just highlighted that in cluster. This one confirms a tumor in a very sensitive area of the back of the brain and early buildup of fluid. Now, even a 1 centimeter mass can cause serious problems in this location, including compression of the brainstem and blockage of cerebrospinal fluid flow. And this one explains the symptoms and increase the urgency for the intervention. So in this scenario, you need to anticipate neurosurgical consultation, and you're going to prepare for possible ICP monitoring and ensure that you are administering the needed medication to reduce brain swelling. Next, we have EEG, showing focal epileptiform activity in occipital region. So this reflects abnormal electrical activity in the brain that caused the seizure. And this one is consistent with a seizure disorder triggered by the tumor. So you need to implement the seizure precautions, monitor for additional seizures, and administer prescribed anti-epileptic drugs. Next, we have glucose of 130 milligrams per deciliter. Even though this is considered mild elevation in the blood sugar, this is above normal range for children, and this is something that you need to address. It could result from the seizure itself, maybe a stress response. And remember that this patient is going to get any of those prescribed steroid medications such as dexamethasone, which can also elevate the glucose level and which can increase insulin resistance. Now, in a child with brain swelling, especially with recent seizure, this hyperglycemia can worsen brain excitability and can contribute to further metabolic balance. And so you're going to report this to the provider, monitor for trends, and manage fluids carefully, especially if the child is NPO for surgery or imaging. This time, we'll talk about the incorrect options, and one of those is no focal deficits under the physical exam. Even though it's helpful that the child doesn't have localized weakness or paralysis, the absence of focal deficits does not rule out serious global brain issues like swelling or compression. Therefore, this finding is not priority Q. Now, if you mistakenly highlighted no murmurs or regular rhythm, that's normal. It doesn't relate to the neurological problem and does not require urgent follow-up either. And when you look into the respiratory assessment, it says clear bilaterally, mild tachypnea, nothing to worry about those. Lungs are clear. A slightly increased respiratory rate is not concerning here. It may be due to the recovery from the seizure or anxiety, and it does not indicate a respiratory emergency either. For the skin, warm and dry, this suggests stable perfusion, very irrelevant to the brain issue. And when you go down to the diagnostic test, chest x-ray, no masses, normal lung sounds or lung fields. This one is unrelated to the current neurological issue either. So let's skip that one. And going into the lab results, hemoglobin of 12 grams per deciliter. This is a normal value for a child and does not contribute to the current brain-related concerns. Same thing with the sodium of 135, even it's at the low normal end of the range. This doesn't suggest any acute electrolyte problem as well. Same thing with the potassium of 4.0 and calcium level of 8.8. Though at the lower limit of the normal range, this is not going to call for any immediate attention. You can pause here and reflect on your answers and compare it with the rationals that I've given you. Let's proceed to the next test item. Before we go do that, it says here, the treatment plan includes levetiracetam for seizures, dexamethasone for cerebral edema, and urgent neurosurgery consultation. And the nurse's progress notes showing that at 8 o'clock, this is the time when the patient arrived in the emergency department with the initial assessment findings. And at 9:30, it says heart rate 108 beats per minute, blood pressure 98/58, respirations 22, response to verbal stimuli, less irritable, normal saline bolus completed, maintenance fluid started, neurosurgery consult pending. Good deal. Let's get into our next test item.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
We are on day 2. So the patient has been admitted to the pediatric ICU, appearing less lethargic with a Glasgow Coma scale of 15. A repeat CAT scan of the brain confirms a stable 1 centimeter posterior fossa mass, and electroencephalogram shows no new epileptiform activity. Surgical resection is scheduled for 2 p.m. with the patient NPO. Levetiracetam and dexamethasone to continue, and a child life specialist supports pre-op preparation. Now let's get into the nurse's progress notes for day 2 at 7 a.m. It says heart rate at 100 beats per minute with blood pressure for 102 over 62, respirations 20, saturation 97%, less lethargic, GCS of 15, patients anxious about surgery, levetiracetam continued, dexamethasone given, NPO for surgery at 1400. At 12, patient is alert, playful, no seizures, blood pressure 100 over 60, heart rate 98, and neurosurgery reviewed, CAT scan, confirmed cerebellar astrocytoma, surgical resection planned, consent obtained. And we have some electrolytes here, sodium of 134, glucose 120, and of course we have the remainder of the test here, the CAT scan of the brain and the EEG. Now let's talk about what your role here. It says drag 1 condition and 1 finding to complete. So the statement is the patient is at risk for blank based on the finding of blank. And here are the options. So the first blank is intended for the condition, and the options are tumor progression, respiratory failure, hyponatremia, seizure recurrence, increased intracranial pressure. For the second blank, your options are no new epileptiform activity, respirations of 24, sodium 134, CAT scan stable, 1 centimeter posterior fossa mass, and glucose of 120 milligrams per deciliter. All right, let's fill in the blanks. For the first blank, the answer to that is increased intracranial pressure. Remember that this patient has hydrocephalus when you refer back into the CAT scan of the brain. This patient is at a high risk for developing this one. All right, because the posterior fossa is a tight, it is a confined space in the skull where even a small tumor like a 1 centimeter mass that you've seen in the CAT scan can cause significant compression of the critical structures like the cerebellum, the brainstem, and the fourth ventricle. Whenever there is compression, this can block the normal flow of the CSF, which leads to the hydrocephalus, and in turn will increase the intracranial pressure. Remember that children have limited cranial compliance, means that their brains cannot tolerate swelling or added pressure very well. So even if the tumor appears stable on imaging, the risk of acute brainstem herniation remains high. And this is a medical emergency that can lead to their respiratory arrest, coma, or death if this is not promptly addressed. Even though the patient will be getting a steroid-based medication such as corticosteroids to help reduce the surrounding edema, but that is not a definitive treatment. We know that surgical resection is planned but has not occurred yet, so the danger is still ongoing for this patient. So you got to be vigilant. You have to monitor for early signs of increased intracranial pressure, and don't forget those signs. Those are vomiting, irritability, lethargy, and equal pupils. Do not forget those. And make sure that you perform frequent neuro assessments as ordered, typically every hour this time. And make sure that you are preparing the patient for surgery and also the family or the parents. And make sure that you communicate any deterioration immediately to the healthcare team. Now, why is this a priority among the rest of the conditions here? Well, when you look into the other options, even though the CAT scan shows no worsening of the The size of the mass, well, the location and the nature of the mass continue to make this an urgent concern. And if you fail to recognize and to respond, this could result to rapid neurological decline or possible death in this patient. Now let's talk about the seizure recurrence. Why is this one is not the answer? Remember that the child had a seizure on day 1, and the EEG showed epileptiform activity, which does indicate the risk for future seizures. However, when you look into the follow-up EEG on day 2, it says no new epileptiform activity. So that simply means no new abnormal activity in the brain, and the child has been seizure-free since starting the anticonvulsant levetiracetam. So the risk of another seizure is controlled with the drug, and there is no evidence of active seizure activity. Therefore, this one is not an urgent condition compared to ongoing threat of increased ICP, which remains unresolved and still potentially deadly. Now let's look into hyponatremia. And on day 2, his sodium level is 134, which is lower than the previous day. Even though this is clinically significant, but usually we don't see those danger signs up until their levels go below 130 milliosmoles, especially if there are symptoms of confusion or seizures, which are now absent in this day 2. And this level of 134 is mild. The patient is asymptomatic. So this one does not pose an acute threat, especially when compared to the mass effect of hydrocephalus. Now, talking about respiratory failure here, when you go back into the assessment findings, the pulmonary function is stable. Their oxygen saturation is 97%. The patient has clear lung sounds, and the respirations is 20 on day 2. Even though it's slightly, it was slightly higher on day 1, it was likely a temporary post-seizure or stress response. But today, we're not really going to pay attention to that. And when you look into the last option here, tumor progression, what is this? Although the child has a known tumor, the CAT scan findings are stable and the child's neuro status is improving. And go back into the GCS score of 15. There are no new neurological deficits or radiologic signs that suggest that tumor is growing. So basically, there's no evidence of tumor progression right now. The more urgent issue that you should pay attention is the pressure effects of the existing tumor, not the growth. So go back into the increased ICP. Now, let's look into the second blank. Based on the finding of what? The correct answer is CAT scan stable 1 centimeter posterior fossa mass. This is the most clinically significant diagnostic clue. And in the posterior fossa, even small lesions can have serious consequences because of their proximity to the 4th ventricle, where the CSF drains, and the cerebellum, which is supposed to control the coordination, and also the brainstem, which controls the vital functions like breathing and heart rate. And the mass is already causing mild hydrocephalus, which means it is disrupting the cerebrospinal fluid flow, thereby contributing to elevated intracranial pressure. Now, when you see stable in that CAT scan result, it doesn't mean safe. It just means the size has not changed, but the pressure remains, and that's what continues to threaten the child's health this time. And what you're going to do here is to prepare for emergent surgical intervention. Whenever there is an order for a steroid medication, could be a dexamethasone, you administer that to reduce cerebral edema. Make sure that you perform hourly neurological assessments and monitor the child for any signs of increased ICP. like changes in their pupil size, if they are vomiting, or if there is alteration in their consciousness. Now let's talk about the glucose 120 milligrams per deciliter here. This one is mildly elevated due to the dexamethasone, which increases the blood sugar. And this is also a predictable medication effect. It's not a sign of neurological compromise or acute risk. And this one, it doesn't support a diagnosis of increased ICP. For the sodium level of 134, this is slightly below normal. And there are no clinical symptoms suggesting it's causing problems. And it does not meet criteria for the hyponatremia needing urgent treatment. For the respiratory rate of 24, this is only mildly elevated. And the rate actually normalized during day 2. So the 24 per hour, 24 per minute was based on the patient's respirations on the first day. Now, with the next option here, no new epileptiform activity in the EEG. Well, when you look into the result for day 2, this said no new epileptiform activity. It suggests that the seizure disorder is well controlled, especially with the levetiracetam. So, for this test item, you have to pay attention into the most significant risk, which is increasing ICP, and which is considered as the most urgent condition because of the tumor's location in the posterior fossa. Man, this one is associated with hydrocephalus and the risk for herniation. Now, when you go back into the data here for the CAT scan findings of a stable mass, this is still clinically significant in this child because of the limited compensatory capacity. And look into the other labs and findings, such as hyponatremia, normal EEG, mild hyperglycemia. Those are low priority and are not immediately life-threatening.
Before moving ahead, here's something you need to hear. If you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
All right, let's move on into our third test item. It says here, day 3. The pediatric ICU nurse develops a post-craniotomy care plan, reviewing the nurse's progress notes, diagnostics, and healthcare provider orders to ensure neurological stability and finally support. At 8 in the morning, this one was entered by the RN. Post-craniotomy, arousable, answer simple questions, heart rate 90 beats per minute, blood pressure 105/65, respirations 18, saturation 98%, head dressing with minimal serosanguinous drainage, central line intact, IV fluids at 50 mL per hour. At 2 p.m., GCS 15, pupils equal reactive, mild headache 3 out of 10, clear liquids tolerated, parents report improved mood but fear complications. And we have an updated results for the CAT scan of the brain and EEG showing no residual tumor, mild post-operative edema, no hemorrhage, and the EEG showing normal, no epileptiform activity. That's a good thing. Now, your task is to select all appropriate interventions for each category. We got monitoring, education, and restrictions. And that is the matrix right there. Now, feel free to pause this video and scan those nursing actions. And when you're ready, you can proceed for the rationals. For the first category, monitoring, one of the answers here is to do neurochecks every 2 hours, especially after craniotomy. That should be your priority, to monitor for any signs that the brain might be under pressure or if there's any swelling. Even though the CAT scan on day 3 only shows mild post-op swelling, it can still raise the patient's intracranial pressure. And since the client is alert and has a GCS of 15, we want to keep it that way. And that's why neurochecks, checking the patient's pupils, their movement, their level of consciousness should be done every 2 hours. And this action will let you know, and so that you can spot those unequal pupils or maybe confusion, which could mean the pressure is going up and action should be done to prevent further brain damage. Now, another intervention is this one: assess headache severity, because this is pretty common after brain surgery, but that doesn't mean we ignore them. And a headache rated as 3 out of 10, basically we're not really going to use the numeric pain scale here, but this is just like an associated number. Well, we're going to have to use the flat scale. And this level is somewhat minor, but it can be an early sign that the pressure is increasing or that there is bleeding. Could be a hematoma forming. And monitoring how the pain changes, whether it improves with acetaminophen or if it worsens, can help you and the healthcare team to decide if they need to do another scan or maybe adjust the meds like dexamethasone to reduce the brain swelling. Another intervention is monitor for clear drainage from dressing, because after brain surgery, a little bit of drainage that is pinkish or blood tinged is usually expected. But if the fluid is clear and watery, that's a red flag, because it could be CSF leaking from around the brain. And that's serious because it opens the door to infections like meningitis. So your role here as a nurse should check the dressing regularly and test for any suspicious drainage for glucose, which is a sign that it is CSF. Now, if there is a leak, the surgeon needs to be notified right away. Okay, I'm talking about ASAP, so they can repair that surgically. Now, the other options here are incorrect. So if you selected by mistake, check blood glucose level, even though it's true that dexamethasone can cause blood sugars to go up, but the patient's level is only 120 milligrams per deciliter. It's not dangerously high. Plus, there's no other known history of elevations. And at this point, the more urgent concern is the patient's brain status. It's not the glucose. Even though it's something to keep an eye on, it's not a top priority in the immediate post-op period. Now, the other one is monitor for jaundice. Well, this one doesn't really fit here. This child had brain surgery for a tumor, not about liver or blood problems. And there is no evidence of liver damage or excessive breakdown of red blood cells. So checking for jaundice is not clinically relevant here. Now, let's look into the education category. And one of the answers here is this one: teach parents to report vomiting. Especially after brain surgery, it can mean that there is increased ICP if there is swelling or pressure near the brainstem. And since the parents are likely the ones who will notice changes first after the surgery, they need to know that vomiting is not just a gastrointestinal issue. It could be a warning sign that needs immediate attention. And it should be caught early. We might anticipate, or we need to anticipate, administration of, could be a mannitol or any other scan that can be done before things get worse. Next option here is teach parents on wound care. Why is this important? Because the incision site needs to stay clean, also needs to stay dry to prevent infection, which is a serious complication after craniotomy. And the parents need simple, clear instructions. Could be how to clean the area, what signs of infection to watch for, like redness or swelling or fever, and when to call the provider. Even though they're not supposed to touch the dressing or incision site, they need to be taught about that ahead of time. And since they'll be the ones doing this at home, we need to properly educate the parents to avoid complications. Now, moving on to the next one here. For the restrictions, one of the answers is no strenuous activity. Why? This is very important because if the child is not, or the parents are not aware about these physical activities, maybe jumping or running, this can cause elevation in the pressure inside that brain. And even something like intense play could raise the ICP as well. It can trigger bleeding. And since the CAT scan still shows some swelling, the brain needs time to heal. So physical rest is non-negotiable right now. Now let's talk about the rest of the options under the education, which I have not really talked about yet. Let's go back to that. Now, the other options, such as instruct parents on acetaminophen use. Why is this incorrect? Even though it's helpful to know the child is taking acetaminophen for mild pain, this is given as needed in the hospital by the nurse. And teaching parents about this medication is important later before discharge, but it's not as urgent right now compared to the seizure precautions or the signs of increased ICP. If you selected by mistake advice on resuming a normal diet, even though the child is tolerating clear liquids, it does not mean they're ready for a full liquid. And when you're pushing this one too fast, it could cause nausea, could cause vomiting, which would also complicate the child's recovery. Again, the priority is about neurological stability and wound healing, not restarting regular meals. Also, let's go back into the restrictions right now. Now, one of the other answers here is to avoid coughing or straining. So this is a teaching that you can provide. This is a restriction that you can share to the parents because we know that coughing, straining can cause Valsalva maneuver, which spikes the ICP. And this is very dangerous after a craniotomy. So what you're going to do here as a nurse, you have to make sure that the child receives stool softeners and also teaching gentle ways to clear the throat, and making sure that we are administering humidifier as well to prevent any of like sneezing or anything that may plug up their airway. Another answer here is avoid baths for 48 hours because immersing the surgical site in water, especially during a bath, can introduce bacteria. This can cause infection. And what can be done here instead is to allow showers or even sponge bath, as long as you're covering the surgical site, and also depending on the provider instructions. But soaking the wound early in the recovery is a no-no. So give it at least 48 hours to heal before risking any exposure. Now, let's talk about the incorrect options here. One is limit fluid intake. Why is this incorrect? Well, going back into the sodium level of 134, it's slightly low and it doesn't indicate a fluid problem like syndrome of inappropriate antidiuretic hormone. Plus, the child is receiving IV fluids to support hydration. And when you're cutting back in fluids, that can lead to dehydration, which is not safe after surgery. So there is no need for fluid restriction this time. The other option is no screen time for 1 week. Well, Going back into the case scenario, there is no evidence that watching screens will harm recovery after craniotomy. And this is not a validated restriction, and it does not affect ICP. So the focus should stay on things that matter, like limiting physical strain and preventing infection, not arbitrary limits. All right, feel free to pause this video and you can proceed once you're ready for test item number 4. We have a bow tie, and this is about 10 days after vincristine initiation. So the nurse assesses for chemotherapy-related complications, ensuring precautions for adverse effects. And we have nurse's notes by the oncology nurse at 8 a.m. 10 days later, heart rate is 120, blood pressure 94/54, respirations 24, temperature 38.6, saturation 96, reports lethargy, poor appetite, mild numbness in feet, no bowel movement for 3 days, mild redness at central site. Parents note chills and abdominal discomfort. All right, let's scan into the lab results. Hemoglobin of 10.8, platelets 80,000, absolute neutrophil count of 300, glucose 115 milligrams per deciliter, sodium 132, white blood cells 1.2, raised to the power of 3 microliter, and blood urea nitrogen of 22 milligrams per deciliter. Your task is to complete the bow tie diagram by selecting the most likely complication, 2 nursing actions, and 2 parameters to monitor. And here's the list of options. For the complication, your choices are seizure recurrence, gastrointestinal bleeding, hyponatremia, neutropenic infection, chemotherapy-induced anemia, and lastly, vincristine-related constipation. Again, don't neglect all those important cues in the lab results and the oncology nurse. These will all guide you to selecting the correct answers here. Now, let's start with the complication. What do you think would be the best bet here? The answer to this one is neutropenic infection. This is the most urgent complication because of the child's absolute neutrophil count of 300. And noting that the temperature is 38.6 degrees Celsius, he is having chills, and there is also redness at the central line site. All these findings point to possible central line infection, which is a medical emergency in pediatric oncology patients, especially that they're getting the anti-neoplastic medication. Now, you might ask, why is this serious? Well, the child has been getting vincristine. This is a chemotherapeutic agent that can suppress the bone marrow, especially the neutrophils. It will suppress that level, and it can hit the hardest around 7 to 14 days after the treatment. And in this case, on day 10, this is the period wherein their levels are going to be going down. And when the child doesn't have enough neutrophils, their immune system cannot fight infections well. And that's why even a low-grade fever in neutropenic patient is an emergency. So they can go from stable to becoming septic very quickly. And here, noting that fever, this is the most common cause of mortality rate, about 20% if not treated right away. So you need to manage this very urgently. Now, the other options, such as chemotherapy-induced anemia, yes, that's quite true. Going back into the hemoglobin of 10.8, yeah, that is expected with chemo. Noting back into the patient's vital signs, the heart rate is 120, which could be the body's response compensating for the low hemoglobin. But overall, the anemia is mild. It's not causing any other major symptoms like shortness of breath or the need for transfusion, and there's no order for that one as of now. So when you compare chemotherapy-induced anemia to the neutropenic infection, well, the urgency is much higher to the neutropenic infection. So that should be of less priority here. Now, talking about vincristine-related constipation, this is definitely a common adverse effect of vincristine due to autonomic nerve damage. Remember that. And the child has not pooped in 3 days, and he is also complaining of abdominal discomfort. So go back into the oncology nurse's notes. And the doctor did not order anything to treat it yet, and probably because they were more worried about the infection. So again, constipation is important to address later, but not the most critical issue right now. Hyponatremia, going back into the laboratory result, 132, slightly lower than the previous days. And vincristine can sometimes cause syndrome of inappropriate antidiuretic hormone, which leads to this, but the child is not showing any signs or symptoms of confusion or seizures that we would expect with more severe hyponatremia. And there is no evidence of fluid overload or orders to restrict fluids, which are usually part of SIADH management. And so the infection signs that we are seeing here explain the lethargy that could better explain why the patient is having this manifestation. Now, talking about gastrointestinal bleeding, look back into the platelet count of 80,000. So this is something that you can expect, but it's not low enough to expect spontaneous bleeding. So here, we usually worry more when they drop under 30,000, and there are no signs of actual bleeding, no blood in the stools, no nosebleeds or gum bleeding. And again, the fever and chills don't go with bleeding. They go with infection. So this is not the highest priority here. Now, talking about seizure recurrence. Remember that the child had a seizure on day 1, but has not had any since after. And the EEG on day 3 was normal, and they're still taking the anticonvulsant medication. And vincristine doesn't cause seizure risk. So the main concern right now is the fever, the central line redness, not about seizure activity. So take note that the seizure is actually controlled with the anticonvulsant. Now let's proceed to the 2 nursing actions here, and your options are consult infectious disease, assess central line site, administer antibiotics, monitor temperature, obtain blood culture, notify provider. One of the answers here is to notify the provider. This is very critical. Anytime a neutropenic child has a fever post chemo, you need to call the provider right away, especially that their absolute neutrophil count is 300. They are running fevers, and this is a medical emergency. The provider needs to give orders really fast. Could be antibiotics, could be doing blood cultures, also the administration of maybe GCSF to boost the child's white blood cell count. And if you're going to delay this is a huge chance for this child to go septic. So this should be your priority. Another nursing action is to obtain blood culture. This is very critical before starting the antibiotics, so we can figure out exactly what bacteria we are dealing with. And since the central line is red and the site around it, that's a clue that it could be the source. So you need to get the cultures using sterile technique. If you contaminate the sample, it could delay treatment, or it could lead to the wrong antibiotics being used. So this is a key diagnostic step that will guide the overall treatment. Now let's talk about the incorrect options here. Monitor temperature. Even though this is a good intervention, but at this point, monitoring alone is not enough, because we already know that the child has fever. It's time to act this time, and just taking the temperature doesn't stop the infection from progressing. This one is supportive, but it's not decisive. So not really a priority intervention. Now, if you selected administer antibiotics, this one is very important. This is something that you will definitely implement once the healthcare provider orders the antibiotic. But when we talk about what nursing action to prioritize, especially in the take action step with a case, we are looking for actions that initiate the care plan, like alerting the healthcare provider and also gathering the critical data and administering antibiotics as part of the plan after you have called the doctor and after you had obtained the cultures, not the other way around. Now, here about assess central line site. This is something that's very important. And you might have already done it, but again, this doesn't actually drive the emergency care plan forward. So notifying the medical provider and getting the blood cultures should be your priority here. And assessing is useful, but it's not the most proactive response, especially in this case. And if you selected consult infectious disease, this is the job for our healthcare provider. You, as the RN here, you don't initiate this one. What you do is to manage the immediate issue, get the blood cultures after you call the medical provider, and you administer the medications once you have completed the first two. So the infectious disease consultation can come after later if the infection is hard to treat or the patient needs specialized input. All right, let's talk about the two parameters to monitor, and the choices are neurological status, platelet count, sodium level, hemoglobin level, absolute neutrophil count, and temperature. One of the answers here is temperature. The ongoing monitoring of the patient's temperature is very critical to see how the child is responding to the antibiotics. And if the fever does not come down, or if it spikes again, it could mean that the child may have a resistant type of infection or something more like serious, such as sepsis, or maybe there's a fungal infection going on. And the temperature parameter tells us if our treatment is also working. So that should be our priority. Another is absolute neutrophil count, because that is the main issue. Our result for the ANC is 300. That is severely low. So you will likely monitor this daily to see if the bone marrow starts making neutrophils again. And it also helps determine whether the child needs medications like the GCSF. So this is very vital for both treatment decisions and infection risk assessment. Now let's talk about the incorrect options, such as hemoglobin. We know that the hemoglobin was low at 10.8 grams per deciliter, but not dangerously so. And there's no transfusion ordered, and this is not really as urgent compared to the ANC result that is very critical. The same thing with the sodium level. Our level at 132 is mildly low, but the child has no symptoms that make this urgent. No confusion, no seizures. So not a priority in the setting of infection. And for platelet count, that's 80,000, even though it's low, but no bleeding is happening. So it's less urgent than the infection that we are worried about. And if you selected neurological status, well, according to the data, there are no recent seizures, and the seizure medications are still being administered. And the child's lethargy is more likely related to the infection rather than a neuro issue. So neuro checks are not the focus right now. So in this test question, you need to recognize that neutropenic fever should be immediately dealt with. You have to make sure that you have done the correct sequence of your actions. Make sure that the healthcare provider is aware about the critical lab values like the ANC, so they can order those interventions like obtaining a blood culture or administering the antibiotic. And so make sure that you can do this as fast as you can, and This is what's expected of you in the NCLEX to measure your competency as an RN, especially in this case. Now let's move forward here. And so this patient ended up having the following orders. It said blood cultures ×2, cefepime 50 milligrams per kilogram, IV every 8 hours for suspected infection, IV fluids 60 mLs per hour. I believe that's normal saline. Ondansetron 0.15 milligrams per kilo IV every 6 hours, fever and nausea. Levetiracetam 10 milligrams per kilo BID. Monitor temperature every 4 hours. Social work consult for family support. Now let's tackle our next test item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
Number 5. It says here on day 10 at 12 noon, the nurse reviews the nurse's progress notes and lab results to determine the primary concern 10 days post-vincristine initiation, focusing on non-infectious complications. Pay attention to the lab values here, and I think these results are quite the same. But anyhow, here's a hemoglobin of 10.8, platelets 80,000, absolute neutrophil count of 300, glucose of 115, sodium 132, white blood cells 1.2, blood urea nitrogen of 22, and the nurse's notes at 8 a.m. it says heart rate 120, blood pressure 94/54, respirations 24 per minute, temperature 38.6 Celsius, saturation of 96%, reports lethargy, poor appetite, mild numbness in feet, no bowel movement for 3 days, mild redness at central line site, parents no chills and abdominal discomfort. At 12 noon, cefepime initiated, blood culture obtained, fluids increased to 60 mLs per hour, ondansetron given for nausea, parents anxious about fever. So your task is to indicate whether each finding suggests peripheral neuropathy, vincristine-related constipation, or hyponatremia as the primary concern. So here's the matrix. All right, so we have a set of healthcare provider orders as well. So here's the matrix with the following observations: numbness in both feet, no bowel movement for 3 days, sodium of 132, abdominal discomfort, weak grip strength, concentrated urine, hard stools, and lethargy. Again, your task is to indicate that finding if each of those suggests either of the 3 conditions. All right, let's talk about the first one, numbness in feet. This one suggests peripheral neuropathy because vincristine is known to cause nerve damage, especially in the peripheral nerves. And these nerves are the ones in the hands and feet. And when they are affected, kids often complain of tingling or numbness in the feet. It's very uncomfortable, which usually starts around 10 days after the medication is given. So this is a form of sensory neuropathy. And you, as the nurse here, you need to check how much feeling is lost. You need to prevent falls, making sure that our child is wearing non-slip socks, make sure that they are closely supervised, and you alert the healthcare provider so the vincristine dose can be reviewed. And this is because neuropathy can really interfere with how the child can walk, how they can play, or do their daily activities. Now, this one is not associated with vincristine-related constipation, even though this is a known side effect, but it comes from nerve damage in the autonomic nervous system, which manages the bowel movements. So it's not the sensory nerves in the feet. Hyponatremia is also not associated here, even though this one can happen due to syndrome of inappropriate antidiuretic hormone, but it doesn't cause numbness in the feet. And the sodium level of 132, well, most kids are not having seizures or obvious neurologic symptoms yet, and so certainly not numbness. Let's talk about the second row here. No bowel movement for 3 days. The answer to this is, of course, vincristine-related constipation, because the drug can slow down how the intestines move. It can slow down the peristalsis because of its effects on the autonomic nerves. And in this pediatric patient, not having a bowel movement for 3 days is a huge red flag. And if we are not going to address this, it could cause severe abdominal pain, it can cause impaction, and also bowel obstruction. So you need to ask about the usual bowel habits. You need to encourage water intake and also increase intake of fiber, and follow up with the provider for a stool softener or laxative. Now, the other options are incorrect. This is not associated with peripheral neuropathy, because that one is going to cause numbness, muscle weakness, but not constipation. So this one is of a different nerve system. Hyponatremia is also incorrect, because hyponatremia can affect fluid balance in the brain, but does not directly slow down the peristalsis. For the third row, sodium 132, this is associated with hyponatremia, of course. And in this setting, it's likely due to a SIADH. And here, the body holds on too much water, diluting the sodium. So when you're taking care of this child, you have to keep an eye for the early neuroscience like tiredness, confusion. You have to monitor the child's volume of how much they are peeing or their urination. And you have to watch the child for any edema and fluid overload. And also report any significant hyponatremia or significant drop in their sodium level for a potential fluid restriction. That's something that you should be doing. Next, we have abdominal discomfort. What do you think about this one? This is, of course, associated with the vincristine-related constipation. Again, this can slow down the peristalsis. And in this manner, you have to palpate the abdomen for firmness or tenderness, check for the bowel movement, and facilitate hydration, dietary changes, and also administer stool softeners, and make sure that the primary care provider is aware of any complications that may arise. Now let's talk about weak grip strength. This is associated with peripheral neuropathy. So this one points to motor nerve involvement, which is another form of vincristine-induced neuropathy. And by day 10, the child may have a hard time gripping things and holding onto some objects. So this not only affects the child's independence, but also can increase their fall or injury risk. So at this time, your role is to assess the child's motor strength in both upper and lower extremities. You need to report any findings to the provider so they can consider modifying the dose of the drug, and also to offer assistance with the parents regarding the task to prevent any injury. Now let's talk about the concentrated urine. Of course, this is associated with hyponatremia. This is a classic sign of syndrome of inappropriate antidiuretic hormone, wherein the body is releasing too much antidiuretic hormone, so it holds onto water and the urine becomes very concentrated. Even though the child looks like they're not voiding way too much, they're actually holding on to the they're holding on way too much water internally, which can lower the sodium levels. And your role should be to monitor the child's intake and output closely, check the child for any swelling, any worsening of their neurofunction, check for the BUN levels, and to report possible fluid restriction. Okay. Another is hard stools. What do you think about this one? Well, obviously, this is associated with vincristine-related constipation, because that's what vincristine can do. It can slow down peristalsis. This drug can cause absorption of too much water from the stool, so it's going to make it hard and dry. And it's going to be very difficult for the child to pass. It's very painful for them to do that. So this will increase their risk of impaction. Of course, this is not associated with peripheral neuropathy, not for hyponatremia either. Lastly, we have lethargy. Well, this is associated with peripheral neuropathy. And this is where clinical reasoning really matters. Lethargy is vague. It can be caused by several things. And with peripheral neuropathy, the child can complain about pain. There could be numbness or weakness, which can make the child less active and more tired. And also, constipation is also associated here, since the discomfort, and there's possibility that there will be toxin buildup from the backed up stool. The child has not pooped for that 3-day period. So this can make them feel fatigue. And so talking about the no bowel movement here. So if they cannot pass within that time frame, think about the possible toxins that may be developing into their bloodstream. So something that you need to worry about. And for hyponatremia, even with mild sodium imbalances, this can also alter their brain function, which can make them fatigue and become sluggish as well. So in this case, when you take on as a RN in this situation, you have to investigate deeper. You have to use other clues, especially sodium levels, the child's bowel patterns, the sensory changes. So these are your basis to pinpoint the actual cause and make sure that you can prioritize those interventions. Now let's have our last test item, number 6. This is about post-discharge and follow-up. At 9 a.m., outpatient visit reports fatigue, occasional nausea, no seizures, fever or bleeding, heart rate 85, blood pressure 100/60, respirations 18, oxygen saturation 98%, parents managing home care, 5-year-old sister fearful but engaged with child life specialist, adherent to levetiracetam, vincristine, ondansetron. So here are the lab values, 14 days, on day 14 rather. Hemoglobin of 10.6, platelets 90,000, ANC 600. So there are some improvements here, even though they're still not in the normal range, but you can see some improvements. And for the EEG, it showed normal, no epileptiform activity. So here's your task. For each category, patient outcomes, family coping, safety, adherence, select all statements indicating successful management. So here's the matrix. You can pause here to scan first those parent statements, and you can proceed with the rationals. Now let me get started with the correct items for the the first category. For the patient outcomes, one of the correct answers here is this one. He hasn't had seizures since discharge. So this statement tells us that the levetiracetam, which is the anticonvulsant medication, is working, because we know after the craniotomy, after the patient had chemotherapy, the risk of having those seizures can be high. And so when the parent is telling you this, and if there is no epileptiform activity, that is a great sign that the treatment plan is working well. And you as a nurse, this is the kind of neurological stability that you should aim for in this patient. Let's talk about the next one. He's eating small meals but drinking well. Even if he's not eating that much, drinking fluids and tolerating small portions is still a win, especially after the chemotherapy, because nausea, lack of appetite, there's a possibility that there's also alteration in their taste. These are expected side effects of the chemotherapeutic agent. And so if the child stayed hydrated and if he's getting some nutrients in, then we're actually supporting his recovery and preventing bigger problems like dehydration. Another statement here is this: his nausea is better with the medicine. And of course, with ondansetron, which is the anti-nausea medication, this is the desired action. And this is really gonna matter, especially in oncology, because when children feel less sick, they're more likely to eat, more likely to drink, and they stay engaged. And this one directly supports healing, and this is going to help them stick with the treatment plan as well. And so the rest of the options here are incorrect. So if you selected his running around like before, well, on the surface, this might sound good, but we have to look deeper. So looking into the platelet counts of 90,000, and when the parents report that they're running and rough play, this increase their risk of bleeding, even injury, especially if neuropathy from chemo affects their balance. So this statement suggests that the family may not fully understand or fully follow the safety guidelines that you have taught them. So this is a red flag. The other statement, he's pale but more active. Well, increased activity here sounds hopeful, but the pallor points to anemia. Remember that the lab results show 10.6 hemoglobin. So that means oxygen delivery is still reduced and the body is still compensating. So even if the child seems more active, this still reflects a lingering issue we need to address. So it's not a sign of complete recovery. All right, let's head into the next category, family coping. And one of the answers here is we're talking to a social worker about our stress. This is a gold star answer, because when they reach out to a social worker, it shows that the family is being proactive about managing their stress. They're not trying to handle it all on their own, and they're using the support system available, which is exactly what we encourage. Another is this one. His sister is scared but plays with the child life specialist, because pediatric care affects the whole family, and involving the child life specialist can help the siblings process their emotions through play and age-appropriate communication. And it's a very healthy way to support emotional resilience for everyone involved. Next, we pray together as a family, and we know that spiritual practices like prayer can be a powerful coping strategy. And so when families lean on their beliefs or, let's say, traditions together, this one builds emotional connection and can help them handle the emotional roller coaster of treatment. And so the other options are incorrect. And if you selected, we're avoiding hospital visits to protect his sister. Well, this statement is understandable. Families are overwhelmed, but skipping support groups means they're missing out on valuable connection and coping tools from others who understand. And this statement reflects an unmet need for emotional or informational support. And the other one saying we are too busy to join, we're avoiding his hospital visits to protect his sister rather. So it's natural for them to protect the other child, and skipping hospital visits can compromise the patient's care. And delaying chemo follow-ups or laboratories due to fear or maybe stress indicates a coping strategy that puts the child's health at risk. All right, let's talk about the last category, safety adherence. One of the answers here is this one. We call the doctor if he has a fever. This is exactly what we want to hear, because the absolute neutrophil count is still low at 600, even though it's improving. But we need to report promptly if there are any reports of fever. This statement shows that they are adhering to neutropenic precautions. Another answer here is this one. We check his central line daily. This is excellent. So if they're checking for the signs of infection or complications every day, this is going to help prevent life-threatening central line associated infections, especially after a recent bloodstream infection. So this tells us the family has learned and adapted well. Another here is he avoids rough play. Remember that the patient's platelet count is 90,000, still low, and the possible neuropathy is still possibly there. And so when they state avoiding rough play, it reflects that the child basically is reducing their risk of bruising, bleeding, even falls. So this tells us that the family understands and also following the critical safety teaching that we have shared to them. Now, the other two are incorrect. So if you selected we're giving ibuprofen for pain, this is a red flag because ibuprofen increases bleeding risk, which is dangerous with a low platelet count. So instead of having them use ibuprofen, they can have them take acetaminophen instead, not ibuprofen or other non-steroidal anti-inflammatory agents. And the other one, we're using a rectal thermometer for fever. Well, this is something that should be avoided because this can lead to mucosal injury and bleeding, especially in a child that had neutropenia and they had thrombocytopenia. And so make sure that they avoid doing this. Even though the intent is checking for fever, the method of checking the temperature is inappropriate. So they should be taught in checking the temperature via axillary or maybe with the use of a temporal probe instead. So this time, let's recap what you should retain from this case study. So remember that in this case study, our focus is about recognizing those neurological cues because of the posterior fossa mass. And we also need to manage those seizure risk and about the surgical interventions that you should anticipate, and also address those chemotherapeutic related complications like neutropenia. So you have to optimize the post-discharge care to support the family and to help them cope and to be compliant with the discharge instructions. So for test item number 1, that was a hotspot. So in that test item, you identified those critical findings in a very emergency scenario of a pediatric brain tumor, which required neuro follow-up. And don't forget about prioritizing those neurological findings, such as lethargy, the mass that was seen by the CAT scan. So make sure that you don't neglect those. For test item number 2, we had the drag and drop rational. So in that test item, you linked those diagnostic findings to the most urgent intervention, also identifying those increased intracranial pressure as the primary risk. Then the third test item, that was a multiple response grouping. In that test item, you developed a comprehensive post-craniotomy care plan focusing on neuro monitoring, parental education, and activity restriction. So in that test item, you selected those interventions that align with post-op risk, pediatric needs, and ensuring family involvement and safety while avoiding non-evidence-based restrictions. For test item number 4, that was a bow tie. In that test item, you prioritized urgent interventions to manage neutropenic infection, and you prioritized those actions such as notifying the healthcare provider right away and making sure that diagnostic test is done, such as obtaining blood cultures, and making sure that you are going to monitor the patient's temperature and their absolute neutrophil count. For test item number 5, this was a matrix multiple choice item, and there you differentiated non-infectious chemotherapy complications and identified those peripheral neuropathy, complication, constipation, and hyponatremia. For test item number 5, that was a multiple response grouping. In there, you assessed post-discharge outcomes to confirm chemo management, how the family is coping after the hospitalization, and their compliance to the discharge teaching. So when you evaluate outcomes, you need to use those specific indicators such as absence of seizure, infection prevention, and also identifying if the family have those behaviors or observe those precautions to prevent those complications from happening. And so that's it for today. And don't forget to subscribe to the channel and click all the buttons and share this video to your friends who are also preparing for the NCLEX. I thank you for watching this video, and I'll see you again in our next review session.